Hello everyone, Dr. David Warmflash here with another flash moment in medical science. Today's topic is acyanotic congenital heart disease. We'll be talking about congenital heart disease, and it's typically divided into acyanotic, meaning that it doesn't cause cyanosis, and cyanotic, meaning it does cause cyanosis. First, let's go over quickly the normal anatomy and physiology of circulation, both in the adult and child and in the fetus. So normally, as you know, blood comes into the right atrium of the heart and passes through the tricuspid valve into the right ventricle. From there, it goes to the pulmonary artery, through the pulmonary circulation, and now the blood is oxygenated, it's lost its CO2, that's been off-gassed. That comes back to the left side of the heart via the left atrium, through the mitral valve, into the left ventricle, out through the aorta, through the aortic valve, aorta, and the systemic circulation. And normally those two circulations are separate. In the fetus, it's a lot different because they're connections, because the fetus is not getting the blood oxygenated and removing the CO2 by way of its own lungs, which are collapsed and developing. It's coming from the placenta. Now you have the oxygenated blood, that red blood, coming in through the umbilical vein, and it enters into the abdomen of the fetus, and at that point it's going to head toward the inferior vena cava, and there are a couple of different routes to do this. It can go through the portal vein and through the liver, lose a little bit of its oxygen in the liver, but a good amount of the blood goes through the ductus venosus, which bypasses the liver, detours around it, and goes directly into the IVC. So what you have coming in to the fetal IVC is extremely oxygenated blood. That's the red blood. That comes into the right atrium, but also coming into the right atrium in the fetus is blood that's deoxygenated coming from the upper body, coming in through the SVC, the superior vena cava, and blood from that right atrium then mostly goes through the foraminal valley. We'll be getting into exactly what that is later in the talk. And some of it goes into the right ventricle, but a lot that goes into the right ventricle will then, almost all of that, will then not go into the lungs. It'll go into the pulmonary artery, but will then pass through the ductus arteriosus, which is a little blood vessel connecting the pulmonary artery to the aorta. And because the pressure is lower in the aorta and higher in the fetal lungs, which are collapsed, most of the blood just wants to do that, go from the pulmonary artery into the aorta, and that's good because this is mostly oxygenated blood. There's a little bit of deoxygenated mix in there from the upper body, but that's okay. This is enough, and it meets the needs of the fetus. Now, at birth, though, this switches to the circulatory pathway that you're familiar with because the foraminal valley closes and the ductus arteriosus also closes. Not always immediately, but they close. So now let's talk about acyanotic congenital heart disease. Now, what's happening in acyanotic congenital heart disease is you have you have some kind of a connection between the left and the right side of the circulation. And because the pressure is higher on the left, as it normally is, you're going to have a left to right shunt. So blood is moving from the left side of the circulation into the right side of the circulation. That could be from the left side of the heart to the right side of the heart, or it could be a little bit after that. It could be from the aorta into the pulmonary artery. Either way, you have less blood than is supposed to be going through the systemic circulation, and more blood is going through the lungs. Now, that does not give you cyanosis because cyanosis you get from the other type of shunt when you have a right to left shunt, where you have deoxygenated blood making its way to the left side of the circulation without getting through the lungs. But there are a couple of caveats that we'll be talking about a little later. One caveat is called Eisenmenger syndrome. In Eisenmenger syndrome, you actually get a reversal of the shunt direction from left to right to left because of what happens in the lungs. And the other situation is coarctation of the aorta, which typically is discussed in a discussion about acyanotic heart disease, because it's an anomaly that doesn't usually cause the mixing, but it can under certain circumstances. So let's go through the different types of these anomalies that are acyanotic. One type is you have a atrial septal defect. That means a defect in the atrial septum, the wall between the right atrium and the left atrium. Now, how does that even happen? Well, normally the septum develops during embryology, and by the time that the fetus is ready to come out, it's almost completely formed, except that the foramen ovale still has a little flap that can remain open only if the pressure is higher in the right atrium. And it actually is kind of like a one-way valve. But there is the septum itself, and there are really two parts to the septum. It's kind of like a double wall. If you imagine the walls in your house, they're not just solid, there's actually an empty part in between, because there's like one wall here, making like a double layer. But not all of the layers are filled in. So what you have is you have on each one, you have something called an ostium, which is a kind of an empty area. And that usually is not a problem because it gets covered by the other wall, the other part of the septum. The only problem is if you don't have a complete other part of the septum right at the place where you have the ostium. And there are two types here. There's the ostium primum and the ostium secundum. And these will lead to two types of ASD, of atrial septal defects. The most common types that you'll hear about on exams, a secundum deformity, meaning a hole where the ostium secundum is, and a primum deformity. Now there are a couple of other types too, but these are the main types, and actually the secundum is really the most common type. So how does it happen? So in between the atria and the ventricles, remember the atria are at the top of the heart, the ventricles are below. You don't just have a septum coming between the left and the right side of the heart. You also have a septum coming between the atria and the ventricles. This is the septum intermedium, which has within it the places where you're going to have the tricuspid valve developing on the right side and the mitral valve developing on the left side. Now, you can have a problem really in any of these septa, in any directions. There's even something called an endocardial cushion defect where you don't get any of it, and that's the worst situation when you have these deformities. Now, when the intraatrial septum is developing, it develops upward from the septum intermedium, and it kind of works its way between the actual superior part of the atria and the septum intermedium. And there's one hole that develops, and then that hole gets filled in, but then you get another hole in another area, and that's called the ostium secundum. But what also happens is this layer, which is called the septum primum, which gets a little confusing because the septum primum contains the ostium secundum. Right next to it, another layer is supposed to build itself down called the septum secundum, and it covers up the ostium secundum. But if there's a problem with the septum secundum, it can leave the ostium secundum open, and that's called an ostium secundum defect. That's the most common type of atrial septal defect. You can also have a primum defect, meaning that the ostium primum is exposed. That's the one closer to the septum intermedium, closer to the ventricle, and that could be exposed because the other septum doesn't cover it, meaning the septum primum. So it can get confusing, but look at the pictures very carefully and learn that. Now, the secundum deformity, that's the most common type. The primum, you get that in certain situations like Down syndrome. That's the most common situation, one of those, where you would get that defect. Now, it's really important not to confuse this with a PFO, a patent foramen ovale. What is the foramen ovale? What the foramen ovale is when the two septa that are forming the intraatrial septum, when they form, you end up with a little flap because of the septum primum, which is the one coming up from the septum intermedium, from the bottom. It goes off toward the left atrium, while the septum secundum comes down, and that normally covers the ostium secundum. And normally right after birth, this flap is going to come down and attach to the septum secundum, the flap from the septum primum. But during fetal life, the flap is open because the pressure is higher inside the right atrium. And what that does is it really causes a kind of a one-way valve. And so you can think of the foramen ovale as a kind of a one-way valve. It's like a swinging door, but it's not like the swinging door when you see those old movies and those westerns where the bad guy walks into the saloon and the two doors start swinging back in both directions when he's ready to kill the sheriff or something. It only opens one way, which is into the left atrium. And because of that, if the pressure rises in the left atrium, which it does as soon as the baby starts to breathe, the pressure will knock it down. And we have another video talking specifically about PFO, patent foramen ovale, and normally after a few months that then seals shut. So even if the pressure occasionally rises up in the right atrium, it'll stay shut. But in a very large number of people, it never seals shut. It stays as a flap, and that's a patent foramen ovale. And in this case, you can have intermittently, you can have right to left shunting. You can even have a clot going through there. But what's important to remember for this video is this is a sort of the opposite situation as an atrial septal defect. A PFO is not a kind of atrial septal defect. It's really the opposite, because in an atrial septal defect, you don't have this one-way valve situation. You have a hole. And there are a few different types of holes you can have. Most commonly, the secundum type. You can also have a primum, and there are a couple of other types that are very rare, something called a coronary sinus defect, or things like that. And why is it different if you have something that's open all the time rather than having like a trap door? The reason why it's different is because the pressure is going to determine what happens with the blood. And if it's open all the time, unlike having the one-way valve, you're going to have the shunting when the pressure is higher on the left side, which is the normal way for things to be. The pressure is higher in the left atrium than the right atrium. And that means unless you have a very small ASD, very small atrial septal defect, you're going to have a good amount of blood moving from the left atrium into the right atrium. That is the left to right shunt. You also get a left to right shunt if you have a ventricular septal defect. There are a couple of different ways you can have that. There is a muscular part of the intraventricular septum on the bottom toward the bottom of the heart, the apex of the heart, and there's also a membranous section. And you can have a defect in one or the other, either one causing a VSD. It's more common to have the membranous type. And then there's this endocardial cushion defect, where you can have defects not only in the septum dividing the left heart from the right, but also the intermediate septum dividing the atria from the ventricles. That is a really serious situation. Now, who gets these? They tend to be in cases of chromosomal anomalies. Down syndrome is one example of this. Now, there's other ways you can also have a acyanotic defect, a left to right shunt, and a very common one is a PDA, a patent ductus arteriosus. That is when the ductus arteriosus stays open. Normally it's closed by about 2 days or so after birth. It turns into the ligamentum arteriosum. And then there's another defect called coarctation of the aorta, where you have a constricted area. Coarctation is just a fancy way to say narrowing. We have a lot of different ways to say narrowing. We also say stenosis when we're talking about the valves being narrow. Now, in the case of a PDA, patent ductus arteriosus, you also have a left to right shunt because the pressure is high in the aorta and low in the pulmonary artery. Now, in part 2 of acyanotic congenital heart disease, we'll resume the discussion with what happens on your physical examination of a child with acyanotic congenital heart disease.